like a Chinese proverb, but it's for Northamptonshire. What I think we can, well, first of all, let's in terms of protocol, we've all been in the meetings when the dog's barking and the kids are running in and you spilt the cup of tea down yourself and all the rest of it. So if possible, for the duration of the meeting, if you can remain on mute unless you need to speak. Thank you very much. We've got some apologies. Kathy Hadley, Teresa Grant, Nick Adderley, Stephen Mould, Francis Shattuck, Councillor Fiona Baker, Darren Dovey, and also most recently, unfortunately, Toby Sanders. But we've been assured that Joe Watt or Naomi will be able to take any of the commentary that Toby was going to give in the strategic update section, mostly around vaccinations, I think. Item 2, notification of requests from members of the public to attend this meeting. There are none. 3, declarations of interest, if any. Hello? Is there a declaration of interest? No? I had a spurious noise coming through the back there. Not me. Okay, no declaration of interest. Great. So board members update. Changes the board membership. Naomi Eisenstadt joins as chair of the NHCP. Welcome, Naomi. Great to have you here with us. Colin Foster, Chief Executive, Northamptonshire Children's Trust, joins the board. Follows an action from the previous board meeting on the 9th of July to invite a representative from Northamptonshire Children's Trust to join. Katie Brown joins as Acting Director for Adult Social Services, who replaces Anna Earnshaw. David Jones has now left the board and his tenure as the chair of Northamptonshire Health Watch has come to an end. David joined the board in 2018, been instrumental in championing the voice of the community. Perhaps also been a bit of a constant reminder to us to treat colleagues with respect and kindness. Will Pope, Professor Will Pope, will join as an interim chair of Northamptonshire Health Watch, but I'm not sure if Will's with us today. We'll have to wait and see. I think finally, very lately, Mike Mayer, financial director at EMAS, is joining us as well. So welcome to all of those people. We've written to David, by the way, to thank him for his work on the board. Item 5 is minutes from the previous meeting on the 24th of September 2020. Do we have any, we'll come to the action log in a second, but any comments around accuracy? Can we sign those off? Okay, thank you very much indeed. Item 6 is the action log arising from that. You get 2 versions of it. Well, there's a rag rated one, and I've got a list here which I'll go through. Some of those actions have been completed. Not surprisingly, COVID is still getting preventing some of these actions from taking place. So from the 24th of September, Lucy Whiteman, Peter Lynch, Cheryl Bird to review the joint NHCP Health and Wellbeing Board Risk Register, and that's on hold due to the COVID response. Tim O'Donovan, David Jones. David's no longer with us, of course, to discuss proposal to improve board engagement. That's completed. Charlotte Goodson circulated draft pharmaceutical needs assessment to the board. That's to be circulated after the 18th of January. There's an update on lack of AMHP. That stands for Approved Mental Health Professional. AMHP provision to be brought to the next meeting. That's an ongoing action. We'll give an update on the 25th of March. Lack of AMHP provision to be presented to the NHCP People's Board. That's ongoing. For the 25th of March. Sam Fitzgerald, Adam Smith and Jane Bowen to look at the possibility of having an apprenticeship training programme for AMHP provision. That's completed. Details will be brought to the 25th of March meeting. Update on flu vaccination to be brought to the next meeting. That's completed. Lucy will provide an update during the COVID-19 update on this agenda today. Update to be given on the future of health and wellbeing forums at the next meeting. We'll give an update on what we think how we think the forum should be integrated into the new unitary structure. I think that's it. Unless there's any comments or clarifications on that, we can move on to item 7, which is board member updates. This is where we have an opportunity to update each other on interesting, exciting things that have happened to us since last time we met. Let me jump in with university. Just a few comments about where we are, given the numbers of students, etc. We had about 500 over Christmas. The university never closes, no matter what you read in the press. No university in Britain has ever closed. We've been open consistently. At the moment, we're doing face-to-face teaching, which started on the 4th of January, but only for a certain number of courses, mostly related to healthcare professions, so nursing, midwifery, occupational therapy, and social work. Our on-site test centre, lateral flow test centre, continues to operate. So people are tested regularly on a daily basis. Some you can just turn up and have a test if you're a student or a member of staff. What we've discovered, interestingly, is that the incident rate inside the university is much lower amongst staff and students than it is outside the university. So we're a haven, a sanctuary of social distance, good behaviour, which is interesting. So we're gathering stats on that, and I'm sure in sometime in the future, when all the dust settles on this, there'll be an interesting story to tell about how what sorts of NPIs work and others don't work so well, based on evidence. Anyway, that's it from the university. Please, the floor is yours, ladies and gents. Updates accepted from anyone and everywhere. Preferably unmuted.
I've got my hand up if that's all right.
Yes, sure.
As talking about lateral flow device testing, I thought I'd give a quick update on that. Obviously, we'll talk separately about COVID in general, but lateral flow device testing is, as you say, one of the tools in our toolbox to help identify not people who have COVID, because it's a different type of test, and that's why there's a very different level of prevalence in lateral flow device testing than there is in the general PCR testing. PCR tells you if you definitively have COVID or not. Lateral flow device testing, it just picks up those people who have a very high viral load. So it never tells you if you don't have COVID, it just tells you if you're infectious. It is less sensitive and specific than PCR testing, but it absolutely serves a purpose from a point of view of telling you on a day-to-day basis, is somebody at risk of giving other people COVID? And it's the test that's used in health and social care environments to help reduce risk there. So a really, really important tool in our toolbox, as I said. One of the things that we are doing based on the work that you've done obviously at the university, but also has been done in health and social care and other universities across the country, is roll it out into the community. So as I'm sure you're aware, we're working with the university to utilise the space that you've been using for students actually for the wider Northamptonshire population. We're looking at that as a potential site. And we're also looking at sites in other parts of the county, obviously in particular with a focus at the moment in Corby as well, because we've got a significantly and quite rapid increase in our trend in cases in Corby. So we'll be able to give you more details about that. We're also working with large organisations, particularly in high risk settings, so manufacturing, distribution, to get those larger organisations working with their occupational health teams to roll out lateral flow device testing to their staff. And we're also just literally about to go live with testing for both police and fire and social workers. So again, just really good news. One of the things that will help us identify people who pose a risk to others, help us identify who needs to be isolating and break that chain of infection. So good news, and we'll all be operational in the next 2 to 3 weeks.
Thank you, Lucy. No, that's great. That's really good news. And just to follow up on this, it's very quick. Within an hour, you can get a result. As Lucy says, you need 2 positives, then with a backup with a PCR test to definitely confirm. But it's a really good tool to have, and encourage Lucy and the public health colleagues to try and roll it out as fast as you possibly can. And we're here to help and support you to do that. Any other updates from colleagues? If not, I can call on Krishni. Are you here? Can you just tell us something about where is she?
I'm here.
Aha, sorry, Krishni. Yeah, I've got you down on my list. You want to tell us something important?
Morning, colleagues. I was a little late. Apologies. I got my timings wrong, and suddenly a reminder came up, and I thought, oh, I'm not where I should be. So a couple of things that I'll take the opportunity to talk about, if I may. One was a particular action around the JSNA carer needs assessment that I wasn't actually at the last Health and Wellbeing Board meeting, but I picked up from the minutes the detail of the recommendations following assessment, and we discussed those at our what we call our healthy workplaces subgroup. And that's a subgroup of the Health and Wellbeing Board, which really just looks at how we might address some of the health and wellbeing needs that we've identified in workplaces across the county. And actually, what I really just wanted to mention as a result of that is provide a little bit of assurance, really, to say that the work that the group did, and particularly colleagues in Lucy's team who I've worked with, was to establish a set of standards around a variety of ways in which we can influence health and wellbeing in the workplace. And one of those was about people with caring responsibilities. So I really just wanted to bring that circle round, if you like, just to say that in our standards that we've adopted and asked our partner organisations to adopt, there's a set of standards around caring responsibilities, which are actually really consistent with the recommendations in the JSNA. So, for example, making sure that employers raise awareness about carers within their organisation, make sure that information is provided about caring responsibilities, carer-friendly policies, carer-friendly employer accreditation, establishing working carers networks, for example. So we had a really good conversation about that, and in fact the plan is at our next meeting on the 27th, Carol might correct me if I've got that wrong, we were actually going to have Northamptonshire carers there to help us just revisit that particular topic. So it was a bit of assurance, really, not to say that we've cracked the issue of carers, because that's a much bigger issue than the healthy workplaces element, but clearly, I think what we know, certainly even within NHFT, is a lot of people don't identify themselves as carers, even though they are. And actually, we had, I think, as part of a national days about knowing carers' rights, we certainly had a get together for some of our staff, and many of them said, "Oh, I didn't realise I was actually technically defined as a carer." So I think, you know, the more we can do to highlight that, the more that can be valuable, and certainly using employers across our county to do that, I think, is a really important point. So I really just wanted to give the board some assurance that those recommendations have been very much played into the workplace health standards that we've been promoting with employers around the county. If I may take an opportunity, Chair, just to make a broader point about the work of the group. In just looking at it all again, I'm really conscious, and I probably will need Lucy's help and others' help to kind of come to a conclusion on this, that we now have a system-wide people board. It also has a subcommittee. This is as under the banner of the Northamptonshire Health and Care Partnership. It has a subcommittee looking at health and well-being of employees. And of course, the effect of the change of unitary authorities also affects the membership of the current group, because a lot of membership of the current group is district and borough representation. So we do, I think, need to do a piece of work really, just to review the future of this group and whether we might want to align it more directly with the work of the Health and Care Partnerships People Board and its subcommittee. So with your permission, I was going to suggest, rather than trying to conclude that here, that I would take that to the next Health and Care Partnership Board to ask, you know, for some help, maybe with Naomi's support as well, for us to just do a small piece of the terms of reference and see whether we can combine it into some sort of shared forum that also takes responsibility for the public health standards. I don't know whether, Lucy, you think that's a good idea. Perhaps you could comment.
Yeah, I think, thank you, Krishna. Lucy's put a comment in the chat box and also her hand's up anyway. So Lucy, please, can you respond?
Yeah, absolutely happy to support that, and we'll work with Ali and Naomi to look at sort of, obviously we're still refining the geography, and therefore that plays into not only which board we should be taking this to as an agenda item, to, as you say, try and sort of get some real grip on the problem, but also it plays into, and then the geographies of the new unitaries and any subsequent representation that we might need. So I'm happy to work across those groups with you to see if we can bottom that out. I did, as you say, Nick, put a comment in the chat box, and I think it's easy for us to forget, just because we're working from home, that actually carer responsibility remains, and for quite a lot of carers, actually going to work is a break from their caring responsibility, and it can put significant strain trying to work in an environment where you are a carer, if you are physically there all the time. So I think it's something actually that we need to be particularly cognizant of at the moment. And with regard to support, just a quick update on social prescribing. Obviously, one of the 4 cohorts that social prescribing is targeted at is carers. Obviously, we had a little bit of a hiatus in progress just because of COVID, changes to contractual arrangements, and us having to reflect on outcome payment triggers and the landscape having changed. We've reprofiled the offer, and we've been working with Life Chances Fund, Bridges, obviously the public health team, and CCG, so me with that dual hat on. We've still got a very positive proposal, which in principle is being supported, and we're just trying to work through that contractual detail over the next month or so to get clarity on next steps. But just to let people know that we have managed to reprofile. We are looking at something still progressing, but we just need to bottom out the detail on that as well. So good news that we should be able to provide some support for carers through that route as well.
That's great. Thank you. Thanks, Lucy. Krishna, does that answer your question?
That's fine. Thank you, Chair. So, so I think we'll, with Naomi's permission as well, we'll perhaps raise that at the next partnership board, just to really, as you say, Lucy, perhaps get Ali just to have a look at that and look at the terms of reference membership and just make sure we have a proposal. So Naomi's put a thumbs up. So that sounds like an agreed action. And in the meantime, we'll have a meeting as planned on the 27th with the current group, but perhaps put any further action on hiatus until we've done that mini review, just to make sure we're focusing our resources sensibly.
Okay, that's great. Thanks, Krishna. Just while we're on this, so I don't know if others have had this, but at the university we've had some requests for people with heavy care duties, or even people with with children out of school, to be furloughed. So we've taken quite a tough line on that, to be fair, because the work still has to be done, doesn't it? So it just falls on other people in the organisation. So I don't know if well, I'll just keep that. I haven't kept it to myself, I've told you. But it may be an issue that some of you face as well in large organisations when you've got lots of several thousand people. It's a difficult one. Yes, Kate.
Sorry, I can't find my hands up button. It's disappeared. I just wanted to update you that we're actually just launched a survey for carers. We're working with Northamptonshire carers at the moment and young carers, just to find out what some of the issues are during COVID. And the other survey that we're just about to launch is around young people and their mental health as well. So if I send it out, if you could circulate it to your groups and communities, we're really grateful. Thank you.
That's great. Thank you, Kate. Thanks, Krishna and Lucy, for the comments there. So let's move on. And item 8 is Northamptonshire County Council update, children's services. Matt's with us, but Colin Foster, is it Matt or Colin who wants to take it?
I was just going to mention a couple of things, if that's okay, Nick, and then introduce Colin. Okay. Yeah, well, thank you, everybody. And just on your last point there about homeschooling and things, I've got a 5 and 8 year old at home, and it is really, really difficult to try and do 2 things at once. And my wife's out at work today, and it is a real challenge. And you can see why I think there's a high proportion of kids actually in school, quite disproportionately high compared to last time, so it does present a real challenge. But anyway, that's an aside. So children's services, there was three main things I just wanted to mention. Since the September meeting, the biggest thing that's happened is the Children's Trust started life on the 1st of November. So Colin will, I'm sure, gives his view on that in a second. But up to the 1st of November, there was a massive amount of work and focus from everybody to get the trust ready and over the line, given the sort of COVID context and everything else that the council has been working on. So that was a real big achievement to get that going, basically. But before the trust started, we had a visit from Ofsted. It wasn't a full inspection, but it was mainly, I can't remember the term they used, but it was a look at the areas that they deemed to be of main concern. And they reported positively. You know, they wrote about it positively. They said the council knows what it needs to do, understands the challenges, and is working on it well. But of course, we've had, and those of us that have been on this board for some time, a few false dawns in the past, and the challenge from Ofsted was to keep improvement sustainable and continuous. So that's what we've got to sort of hand on the challenge now onto the trust, really. And I was just going to mention free school meals. There was a lot of news about that, and you know, going back to I think it was the October half term or the autumn half term, where we put a scheme in quite late, but it worked. And I go on calls with county council leaders up and down the country, and from what I can understand, the scheme we put in place in Northamptonshire had a really high and good take up. So that's encouraging on one hand, but on the other hand, it does highlight that how reliable some families are on you know, these the help that they can, those that are eligible. And of course it's rumbled on. It was all in the news yesterday. We continued the scheme over Christmas. We have had quite a lot of funding from government in different pots to cover different elements, and hardship funds through districts and boroughs as well, working with them. But that was a challenge, but I think we've done a pretty reasonable job in that regard in Northamptonshire. So without taking any more time, I'd like to introduce Colin, if that's okay. The trust, as we know, still belongs to NCC until the 31st of March, so it's still our entity. And then, of course, it belongs, it goes into the ownership of the two new unitaries. So if we could just hand over to Colin, if that's okay, Nick.
Yeah, thank you, Matt. Welcome, Colin.
Thank you, Nick. Thank you, Matt. And I following on from what Matt said, really, I think that really is a key point, that the trust is wholly owned, the Children's Trust is wholly owned by the two new unitary councils. So, you know, I think my first message is that we are well and truly part of the Northamptonshire family. And it's really nice to be here personally. What I've been struck by is the quality of the social work staff, early help staff and business support staff that have transferred over into the trust. Some really good people, local people as well, that do a good job to help children, young people and families. I've been really impressed. I think the challenge really is to bring some stability to the leadership of the trust and ensure that we are driving through effective change for children, young people and families, and working well in partnership together. I think that what I hope to bring is that consistency. I live locally. I'm just up the road. I have no intention of going anywhere. I'm into this for the long haul and looking forward to working with everybody. I've been really struck by the quality of the partners that I've met so far. I mean, Nick, I think it's fantastic to see the university stepping up and chairing the Health and Wellbeing Board, which I've never experienced before. So that's great. And had some really good conversations with Lucy and as Director of Public Health, and Ali Gilbert from the CCG, dealing with a few things recently. So I think that the goodwill and the strength of partnership is there. What I want to make sure is that the Children's Trust is a key partner in that, and a key player to, you know, as we develop integrated care systems, etc. So you know, what the message I give is that I'm at the end of the phone, at the end of the email, and always happy to meet and catch up if there's any issues. And above all, I think if there are any concerns or any issues, even if they're historical that folk have, please do get in touch, because, you know, I really want to make sure that we're an equal partner in this environment, and that we continue to improve things as part of our partnership. So yeah, looking forward to working with everybody. I think it's probably worth just giving, you know, that's kind of the headlines for the trust. You know, I think it's probably worth giving a brief overview of response to COVID, if that's okay. And as I say, it's a real challenge. We are where children are at risk. We're fully risk assessing each case, and where a face-to-face visit needs to happen, that is still being undertaken with appropriate protection. But that is important to ensure that children are protected from significant harm. The response to COVID, as Matt rightly said, when the full lockdown was around last time, has been recognised as good, and that we're continuing on that basis with everybody, because we want to make sure that children are supported where they need to be supported, and there's the face-to-face visits happen or remotely where that's appropriate to do so. So yeah, the proof of the pudding's in the eating. I do not intend that this is a false stone. I intend it is a real start to change improving outcomes for children in Northamptonshire, and I'll do my best. And that's it.
Brilliant. Well, thank you. Thanks, Colin. And you rest assured you got the support of all the board in that endeavour. Any update on when Ofsted might come knocking again? Matt mentioned briefly that they've been there with a sort of, I guess, sort of kicking the tyres unofficially, but when can we expect the knock on the door?
Sure. So the inadequate status of Northamptonshire means that Ofsted do a number of monitoring visits before they do a full visit. So one of those monitoring visits has formally happened. There was obviously the COVID visit in October, as Matt mentioned. And what we can anticipate is between 3 and 4 monitoring visits over the next 12 months. And then I would anticipate the full inspection in 2022 at some point. But I think given the challenges Ofsted have got through the pandemic as well, and I think it very much is a movable feast. And as you well know, in any of the inspection what we have to work with is that they'll never tell you exactly when the big inspection is. So but I have to say, and I'm happy to say this publicly, is inspections in all our worlds come and go. What's important is doing the day job right every single day. And that's the message, certainly. I was fortunate enough to do briefing sessions. One of the advantages of Zoom is that I was able to engage with over 600 staff in the system over a period of a few days, in short, sharp sessions, and that's very much the message. Is all I ask is that you do the best job of your life every day. Quite a simple ask, but I think it's important that we keep that focus on improving outcomes for children, young people, and families. And if we're doing that and we're doing it well, then inspectors will come up and they will hopefully recognise that. And that's definitely my hope.
Thank you. That's great music to our ears, I'm sure. And thank you for your enthusiasm as much as anything, but also the professional nature in which you're going to turn this around for us. Any comments for Colin, either in the chat box? Lucy, you still got your hand up, Lucy. Is that a legacy hand, I guess? Is it?
Apologies, it is a legacy hand.
Who'd have thought we'd be using the word legacy hand 12 months ago, but there you go. Right, so we move on then, folks. Thank you both. Thank you, Colin, and thank you, Matt, for that update. That sounds excellent. Item 9 is future Northants updates, verbal. Ian Vincent.
Yeah, thanks, Chair. Quite a few things have happened since our last meeting. One of the more significant things is that we are very close to agreeing the budgets for West and North. Both have been to shadow executive meetings very recently. Quite a major task in itself to amalgamate the budgets of 8 authorities and move them into 2 completely new separate organisations. But that work has progressed really well. I think I mentioned last time about senior appointments. All the executive directors now, and we would call them tier 2 posts, are now filled. We're now this week, next week, and possibly the week after, filling the assistant director posts. And at that point, we will have a full senior management team in place ahead of the go live date on the 1st of April. So that's really quite important work that's going on at the moment. Some of those posts obviously have not necessarily all been recruited from inside. There's been external drive to move to appoint, as well as inviting internal applications. So that's that. COVID still causes us issues, and obviously Lucy's already spoken about the work that's going on in parallel to Future Northants. I think what I would say from an organisational perspective is that there are some real pressure points in the existing authorities, particularly around environmental health officers in the districts and boroughs, and Revs and Ben's staff, strangely, because we now have a myriad of grants that we're administering from central government, not necessarily always with very clear instructions as to who they're aimed at. But coming back to the mental health issues, there are business owners out there that are absolutely on their knees. And I don't mean that just in a financial sense, but they are really suffering mental health issues. And so we are trying to do all we can to be as flexible as we can within the rules that central government sets in terms of how these grants are managed. As I said, there are two or three real pressure areas that COVID is still applying to the existing authorities. But despite that, I think what I would like to just say overall is the programme is still very much on track. We've only got 2.5 months to go. So you can imagine we are now really into the fine detail of the transition from 8 to 2. And an awful lot of work is being done. In fact, it probably over the next couple of months will transition from the business as usual stuff that authorities do well at the moment into more and more staff being hooked up to working towards the go live date on the 1st of April. I don't anticipate any reduction in service levels at all. I say, despite again the fact that we are still in the middle of this wretched pandemic. So that's that. You probably heard some various stories, some generated by the press, some response to the press by central government on what will happen in May with the elections. I think that is causing some concern locally, because clearly what we don't want to find is, having transitioned from 8 to 2, that we have a hiatus in the statutory functions that councils have to fulfil. And if the May elections, I do say if, because the government's position was clear yesterday that they intend the May elections to go ahead. If they don't go ahead, we are putting in place contingency plans to make sure all the statutory stuff that we need to cover is covered off. So that's that. I think those are the main points. As you can imagine, an awful lot of work is going into this now by an increasing number of people. So responses out from local government might be a little bit slower than normal, but generally speaking, things are being kept very much afloat, both for the existing and for the preparations for the new. I'll leave it there, Chairman. If there's any questions, happy to answer them.
Thank you, Ian. Any questions? Matt.
Thank you, Nick. It wasn't a question, just a comment to support everything Ian said there, and recognise, I'm sure all of us, the different institutions and organisations we're working with are working incredibly hard. But I just wanted to point out, you know, everybody's doing the day job and been working on this massive project in the context of COVID. And there's, I think, hopefully we can look back with a lot of pride to say we've an awful lot has been achieved in some very testing times. And that's testament to you know, everybody in these organisations from top to bottom to deliver hopefully these two new, with ambitions to be outstanding new unitary councils for the residents of Northamptonshire. It's been a huge task and continues to be a massive challenge. That was all. Thank you.
Thank you, Matt. Actually, Ian, when you were talking about negotiations picking up a pace, I had this sort of flashback to Brexit. We're not going to see lorry queues, are we, in the A45 between the two unitaries?
No, I think that all that is becoming very clear how we do.
Okay, thank you. Apologies for the flippant comment. But great work going on, and it's incredible how fast it's all come around. So congratulations to everybody who's going to make this such a success. Item 10 is the Better Care Fund, the IBCF, and the Frailty Workstream update. Just for new board members, the Health and Wellbeing Board has got a statutory duty to scrutinise performance of these things, the BCF, etc. And it's undertaken through this quarterly review of performance updates. So can I invite, is it Katie or Sam to talk about the BCF quarterly update, and Ruth Harrison from KGH to provide the ICAN programme update? Is it Sam? Is it, or is it?
It's Sam. Good morning, everyone.
Morning, Sam.
Okay, thank you. I've prepared a report which you've probably had the opportunity to look at. Just to note, this is a Q2 report, so there is a lag in the data, so we're always looking retrospectively. So I'll run through the headlines of that report. Like everything else, COVID has impacted on the requirements for the reporting on BCF and IBCF, so there is no requirement for us to formalise a plan, and our efforts are focused on the response to the COVID-19 pandemic. But what we have agreed as a system is that we would roll forward the schemes and plans from the last period. So there's four main key performance indicators that are covered off via the BCF and IBCF. The first one is a reduction in non-elective admissions into our acute hospitals. And the Q2 report did show that there have been a reduction in non-elective admissions into hospital over that period, which is a positive trend, but very different to where we sit today. I'm going to caveat that, and obviously my health partners will be better to talk about that. The second requirement under the BCF is for the reduction of delayed transfers of care. So those individuals who are medically fit for discharge and need onward settings. On the 19th of March this year, the National Discharge Guidance was published, and that suspended the need for recording of delayed transfers of care. And there was very clear guidance put in place about how we would expedite discharge. And again, Adult Social Care and all of our system partners have worked together to make sure that we expedite discharge really quickly, so there isn't any figures to report on that area. The third section that we report on is the reduction in admissions to permanent residential and nursing care. And over period 2, we saw a significant reduction in those individuals going into permanent residential care. Not only because there was a reduction in customer volumes, but we adopted a discharge to assess model, which meant that no individual was assessed within an acute hospital environment. So that would have had an impact. And it also means that we were able to get better outcomes for people. So some of those people who went to temporary beds, we were able to get home, which is really positive. And the last indicator that we measure is the proportion of people over the age of 65 that remain at home 91 days after discharge. And when we say home, that's the place that they came from. So that could be a care home or indeed their own home. And again, we saw that there was an improvement in that performance in Q2, that more people remained at home 91 days after discharge than in the previous quarter. So that's an overview of the BCF and IBCF current position for Q2. And of course, I'll bring Q3 to the next board. I'll pause there, Chair, in case there's any questions.
Yeah, thanks, Sam. Any questions?
There's not a question. Sorry, Nick, I've put my hand up. There's a question.
Sorry, Lucy.
I think it's just a statement. I think quite often adult social care and domiciliary care workers, care homes, etc., aren't championed and heralded enough for the work that they've been doing under some really, really difficult circumstances. We very often focus our thanks and our congratulations on the NHS workers. And I just thought it would be nice to potentially take the opportunity just to say thank you to everybody who has been supporting both yourself and the team, Sam, because I know coordinating this is, you know, a huge task, really complex and quite often thankless. And I want to make sure that people do recognise just, I think, how much the partnership between health and social care has progressed because of COVID. You know, every cloud does have a silver lining in some cases. We've learned a lot in the way that we've worked together. Haven't always got it right, and I think we'd hold our hands up to that. But I think we've made, you know, giant steps forward with regard to integration, which obviously again is part of the statutory function of the Health and Wellbeing Board. And as I said, you know, you've maintained a brilliant service under some really difficult circumstances. So just I think it would be nice for the board, again, just to acknowledge that formally and make sure that all of the staff are aware that we are very grateful.
That's very well said. Thank you, Lucy. So Sam, please take that as full endorsement for the brilliant work that you guys have been doing. And let's, I guess we're not on item 11 yet, but this whole idea, so that's we'll pick up on that in the next item, I'm sure. Matt, did you have your hand up? Is it a legacy? Yep, it's down. Okay, thank you. Sam, do you want to update us on IBCF?
I'm just going to say Thank you. I'm going to pass that down to the teams because they have worked tirelessly, as everyone has. So I know that's going to be really appreciated. And, you know, this has been a collaboration. The system has worked incredibly hard together. And I think we've made really positive steps for that, you know, that integration. I've got Ruth has joined us on the call, so she's going to give the ICAN update, if that's okay.
Yes, please. Thank you, Ruth.
Thank you.
Thank you. Thank you for inviting me along today. I'm delighted to be here. I've got a presentation which is kind of being shared with you. I won't take too long over this, I hope, but I did want to, first of all, update you on where we've got to. Joe Fawkes, I think, came to the meeting in November, and at that point we were midway through the assessment phase. We have since then completed that. So if we go to the next slide. So the ICAN programme, let me start quickly from the beginning. Integrated care across Northamptonshire. Back in 2019, which seems an eternity ago, there were challenges identified, and we realised that we couldn't just continue as we were. We've got this burning platform and we have to change. I'll come on to exactly the reasons why. But in autumn 2020, we started the assessment, working very closely with Sarah and her teams to look at what the opportunities were. We had an assessment done by Newton Europe, who are also working with NAS, and we'll come on to those results in a second. So if we have the next slide. In 2020, this is a schematic of Northamptonshire as it is, with the 2 acute hospitals very much being the focus for frail patients. We're looking at all the frail patients across the county. And some of the facts on the right-hand side, which are quite scary, just looking at how much the over 65 population will increase by in the next few years, what that means for acute hospital beds if we carry on as we are, what it means for social care, what it means for our emergency departments, and just what it means for the overall health and social care system. Next slide, please. So if we don't change in 4 years, we are likely in Northamptonshire to need 150 extra GPs, 10,000 more admissions a day, spending 120,000 more a day. We'll need 568 more hospital beds, which is a terrifically scary figure, meaning that we will need most definitely a new hospital, and that social care would need to deal with 2,500 more requests for social care support. Next slide, please. So the ICAN programme was set up. This is our much loved little ICAN house on the right here, with 4 pillars, which are primary and community, frailty, discharge, and then NAS Tom. As I said, NAS were doing their work before us, they're leading the way. And we had our aims, which was to make sure that we chose well, that no one was in hospital without actually a need to be there, ensuring that people can stay well and stay at home if that's the right place for them to be. So I think you will probably have seen that house before. I'll move on to how it's changed over the course of the assessment. Next slide, please. So what did we do during this assessment phase? So with Newton's support, we had discussions with more than 300 staff, looked at more than 1 million data points, reviewed every bed, relevant bed in the system. So 720 beds and patients in them were reviewed, had surveys, and we did in-depth case reviews with over 65 practitioners, as well as shadowing frontline staff. We tried to involve all the organisations that we could. I mean, I've worked in health all my life. I've never seen such good and positive system working as I have here in Northamptonshire. It's been brilliant. Move on to the next slide. So I'm going to ask Jo Watt to come in here because she obviously has day-to-day contact with the patients and can give it that added meaning and colour. So Jo, are you happy to pick up the next few slides?
Thank you, Ruth. That's helpful. So I think really just building on it, and I think linking it again to COVID as well. This is not a separate effort. This is particularly important, and one of the key tenets of our actions against COVID is to stay home. So this is even more important now than it has been at any time, that we support our frail patients to stay at home, and really looking at some of the reasons why people may go to hospital And we have also an opportunity here where our population's mindset is changing about whether they want to be at hospitals, preserving those for people who really need it, but also wanting to be at their homes. And I'm just going to take you through just a few case studies, some of the cases that we've looked at. And I think the thing to emphasize here is these cases have been looked at as a multidisciplinary team. And this is a really important way for us to work together. It's not about one professional, it's about all of us working with the person and their carers to work out what it is that they need. This is not about one professional making a decision on behalf of that person. And it's a really important mindset change. So essentially, this was a lady that we were looking at. These are obviously all anonymised cases. This is very much looking at to see what it is that somebody needs. I'm not going to read through the slide. I'm sure you'll read through that yourselves. But looking to see what is it that we need. And sometimes these things can be really simple. So it's about helping somebody with their prescribed medication in order to avoid admission. It's not always going to be about a very complex care package. Some of these interventions are very simple, but they may involve services that we don't currently have and will maintain people's independence. Next slide, please. Again, what we're looking at here is there will sometimes be times where people do need to touch hospital services. So with this gentleman, this is a gentleman who had a fall, who did require an assessment. And obviously we work really closely with EMAS services. I know, having spoken to EMAS recently, the communication between EMAS and people's registered practitioners, where there is an ability to keep somebody out of hospital, that absolutely needs to be done. And this gentleman absolutely did need an assessment. So he needed an assessment in hospital, but what he didn't need was to spend time in a hospital bed after that assessment. So it was very much looking at what are the services that we have available. Many of these are already available. And some of the things that we're working at within the ICAN series is about helping staff to understand what is already available, as well as developing new services or changing current services that better support people to maintain their independence in their own home, wherever that may be. And so this is very much about looking at what other team members can you use, supporting this gentleman after he's had his A&E assessment to actually get home as quickly as possible. At the moment, nobody wants to stay in hospital if they don't need to. This has always been the case, but it's particularly pressured at the moment with the amount of COVID cases that do need to be in hospital. We need to support people who have COVID. We need to support people who don't have COVID and get them home as quickly as we can. Next slide, please. And again, what we're looking at here is somebody who has had a fall. I think we absolutely need to pay tribute to our EMAS services, who are very good at assessing people. Where possible, those people will stay at home. And I know that not conveying people who don't need to be conveyed is really important. But again, there will be people who require a frailty assessment. We need to understand not only have they injured themselves, but also why did they fall in the first place? And it may well be that a number of investigations are needed, but that somebody does not need to stay in hospital to have those investigations undertaken. And this is really a much better pathway. So this describes somebody, again, who has their assessment, but who then is able to stay in their own home, and with the skilled nursing and therapy staff from intermediate care, that allows people to stay at home. And equally, some of these patients might also require interventions supported by our colleagues in adult social services. And it's making sure that that person gets the care that they need, and that's in the right place. Next slide, please. And I'm going to hand back to Ruth. Thank you.
Thanks, Jo. So what the ICAN programme did was try and look at the individual case studies, as Jo's just described so well, and look at, if you look at that right across the system, what difference will it make to the system in the future? At the moment, we've got 131,000 people over the age of 65 who live in Northamptonshire. Every day, 27 access urgent community intermediate care. And every day, 165 over 65s come to the emergency departments, 92 of whom are admitted into the hospital as emergency admission. So if you look at any one time, we've got 640 over 65s in hospital beds. And what we tried to do through the ICAN assessment was work out with all the staff concerned, with the multidisciplinary teams, where we could change things to improve that situation. So 75 to 79 of those admissions, we believe, could return home quicker than they currently do. We know that lots of the people who we discharge at the other end, we quite often discharge with more support than they actually want or need, which is really not allowing them the independence that they want. So we are working very carefully with NAS to make sure that we can discharge patients home with the level of support, the right level of support for them. And when we did the assessment of the hospitals, I think this is a very impactful number. At any one time, 170 more people could be at home, not in hospital, if we made the changes that we'd identified. So move over to the next slide, please. So from having done all the work across the system, we believe that 10 people every day could avoid escalations, that 16 to 18 more people who come into hospital could actually have their needs met in the community. We would need 170 fewer beds, and we could save the system £18.5 million. So again, massive figures here, really, really important changes to move ahead with. Next slide, please. So this is sort of our vision of you remember back to the 2020 slide where everything was very much focused on the 2 acute hospitals. What we want to do for frail people is change that so that we have community hubs. The first place a person in trouble would go would be their community hub, not the ED. And we've got several down the side. You'll see some of the points that we want to make. Definitely should be about community hubs. We accept that it will mean a move of resource across the system. It's a difficult concept, but we do know that without developing the services in the community that are required, we won't make the change that we have to. We're very much about removing the organisational boundaries. Every work stream, every project has cross-organisational membership on it on this. There's no silo working at all. So it's a completely different way of working to the past. We hope that eventually we will lead to a smaller acute bed base. That I think is what everyone wants. The staff want it. It's more satisfying for them to be working with patients that genuinely need their help, not patients who feel that they are stuck in hospital. Patients never want to be in hospital if they can avoid it. We all know, particularly in these times, it's not the best place for patients to be. So it's trying to make sure that we get all the systems behind that, everything right, to enable our vision for 2025 to come true. Next slide, please. So some of the statements, we have these TOICAN statements where we try and listen to patients, to their carers, and hear what they're actually saying to us. And what we were hearing from the assessment was that lots of people didn't know how to access services. And that wasn't just patients, that was actually, as Joe mentioned, quite often the staff out there don't know which services are available and how to best access them. They believe, and we've evidenced it, that they could get transferred or admitted to hospital when they don't need it. Very often we don't listen to our patients to feel that, and they feel their choices aren't being heard. We don't have the services out there that are available to maximise the number of patients that we could keep in their own homes. I've already mentioned the one about independence. Sometimes we discharge patients to places where they don't maximise their independence. And the one at the bottom, I'm sure will strike true to several of you. They have to repeat information over and over again to different professionals, which is incredibly frustrating if you're not feeling at your best. So we want to move to 2025 vision where the right choices are available to the individual. The right services are there to help people maximise their independence. They can be sure that they will get the right treatment. They'll get the right care and support to help them manage in the most independent setting. And that they know that when they do require health and social services, the care and support is in the right place for them. Next slide, please. So this is our roadmap. We were trying to look at our 2025 vision and how we'll get there. This is not a rapid solution. This is a 5-year plan. This is saying that over the next 5 years, with the ICS coming on board, with several of the changes that are already in place in the system, we will gradually move towards the vision to achieve it for 2025. Each one of our work streams is developing their own roadmap to tie up with this. We know that we will have to say community hubs will be developed, rapid response services will be developed. We want to make much better use in the county of things like remote monitoring. The technology now is incredible. We've got to make use of it in Northamptonshire to actually try and keep people out of hospital. So that's our roadmap full of happy people. On to the next slide, please. So I said that we'd mention how the house changed over the course of the assessment. We've now moved to 3 pillars. Mass is part of each pillar. So we haven't got them as a separate pillar anymore. They're fully integrated. And we have a community resilience pillar, which is basically looking at the community services that are available, both preventing admission in the first place and helping patients leave the hospital on discharge. It's an incredibly busy pillar. I'll show you some of the programs that they've got. We then move on to escalation and front door. There are times when frail patients will need to come to hospital. We know that, we accept that, but it's important that when they hit that hospital front door, they are helped in a way that is most suitable for them. If they can be turned around and got home on the same day, we can do that. We want to make sure that they are always treated by staff who have training in how to deal with frail patients. And then if they have to be admitted, there's this work stream there called flow and grip, which basically means that their process through the hospital is as smooth and straightforward and quick as possible. And it's all the things I'm sure that you will be very well aware of, things like making sure that their drugs are ready to go home with them when they're ready to go home, making sure that transport is the issue, all the areas about making sure that every day there's a ward round that checks that that patient is on to the next step in their treatment, that they're not left in beds for days without active treatment. And underpinning all of those clinical pillars, we've got our sort of foundations, which we know we have to get right. We've got to get the data right. We need one single truth that everyone in the system understands. We don't want people to be having to give their basic details every time. We need a lot of work doing on the IT side. We've got lots to do about communications. Already, and Joe mentioned too, that there are services out there that are not necessarily running at full capacity that staff and patients don't know about. We have to improve our communications, and we've got quite a lot of work going on that. So just to give you a bit more detail about what's been happening since the assessment finished. Could I have the next slide, please? We've got our 3 pillars. Each of them has identified the key areas that they want to change in the short, medium and long term. We're calling them bricks because they make up the pillars, and it makes more sense. This is the community response, as I said, incredibly busy. I think they at the moment have 24 bricks making up their pillar in total. But a number of these are things that will already be starting to make changes. So things like the work with EMAS. It's been going on now for several months. It is really making a change to the way we bring patients into hospital, to the pathways. We've been working with the care homes, getting DES implemented. And a really key one is this high quality holistic care plans for all older people that are regularly reviewed. So that starts out in the community. We want to make sure that that care plan is then available to EMAS if they're called to a patient, so they know that the circumstances surrounding that particular patient, that the patient is conveyed into the emergency department, that as soon as that call is made, the frailty unit can have a look, understand the background, understand what's been going on, and that can then be turned around so that the patient comes in, is sorted out if needs be, and that is then immediately updated so that back in primary care, they're instantly aware of what's happened. So lots to do on that community response pillar, and you'll see that in the long term, we have got things like the remote patient monitoring I talked about at scale across the county. So some of these things will take a long time, but they're absolutely all essential. Can I move to the next slide, please? The escalation and front door pillar is what happens if patients do come and hit the hospital front door. Now, we already have some excellent staff there. We have things like frailty phone where anyone can ring up and talk to one of the team to get advice and care. But again, it's not particularly well known. So we've got to do something about making sure that people are aware of that and use it more. Data capture, I've already mentioned. We have slightly different systems at NGH and KGH around frailty model. At one, we have a frailty unit, and the other, we have a frailty team. The frailty teams across the county want to look and decide what is the best model moving forward and then use that consistently. If I can move on to the next slide, final pillar is our flow and grip. This is the one where it's actually inside the hospital. And I'm sure you can read through those, but just a few of the things, a few of the quick wins, I suppose, that we've had. Discharge coordinators. We now have much better access to discharge coordinators right across the system, and they are working as a system resource. So that's changed massively just in the past few months. We've got things like increasing the utilisation of IV medication services in the community. The number of those, they were running at 1 to 2 a week, they're now up to 30. You know, changes have happened already. We know that we won't get to our vision for several years, but we know that in the intervening period, every time we do something positive along this path, it's going to help the people of Northamptonshire. So thank you for listening to me. I'm very happy to take questions or comments.
That's great. Thank you, Ruth. Very clear. There's some comments in the chat box. Perhaps you can go through them. One first is from Naomi, who'd like to understand a bit more about preventative services, so podiatry, sight, etc., hearing, for the over 65s to becoming frail. Joe, can you answer that question for us, please?
Yeah, so I can start to make an answer of that. I'm not going to pretend that things are perfect at the moment, but I think really just to describe that a lot of this is underpinned by multidisciplinary working, but this is not just about health professionals. So one of the things that people may be aware is obviously we have 16 primary care networks. Those have started to recruit new members of staff, including social prescribing link workers, care coordinators, and there's a whole range of other staff that can link. By including your social prescribing link worker, and I can speak from personal experience because ours is part of our multidisciplinary team, that allows that person to be connected to all of the other services. And I think this probably brings in some of the other comments in the chat as well about other services that allow that person to maintain independence, to allow them to connect with their community. Certainly the social prescribing link workers are now very much connected in with a lot of the specific COVID response, but also non-COVID response within the districts and boroughs, and also will connect in with the unitaries as well. And they have a really good system for disseminating information about how to support the population, how to allow them to access those services, making sure that the knowledge is there. For some people, it's just they're not sure how to access those services, but really very much promoting independence. And we also have a lot of work being done on the data feeds within the county, looking at not only people who have been in contact with services and are discharged, but those people who are becoming more frail. And there's a large piece of work that's taking place across the whole county to look at that data, to know and to flag people up to their registered practices so that they can be connected in with services. It is a huge piece of work. It is really important that we work across not only health and care, but actually the wider public sector as well, to know what are those services, how do we support people in their homes. Links with things like the fire service are going to be absolutely essential to that. And as I say, the multidisciplinary teams, the way out at the moment is through care coordinators and social prescribing link workers, but equally that could be the way in, and people can start with other services and then feed into those more complex teams where the needs are greater. So it's about different levels of multidisciplinary team, depending on whether somebody needs a more universal type approach to things or has more complex care and needs geriatricians, GPs, social workers, more complicated care. So it's about the flexibility and making it very much person-centred, and really quite optimistic about the way that we've been able to work across organisations. And as I say, linking in with districts and boroughs has been an absolute joy. And there are so many services out there that can maintain the independence of our population. As I say, even with EMAS. So I recently discovered that there's a specific frailty worker within EMAS, happy to join multidisciplinary teams and avert admission. So we've got all sorts of people. It has been brilliant. And actually the new technology has allowed us to work in very different ways to make it very person focused. So hopefully that answers the question.
Sure, I think so. Ian, very good. Yes, we can send the slides around. That's well, I'm sure that we can. Ruth will confirm that, but I don't see why not. Interesting from Lisa Bryan, actually, talking about the fire service preventative programs, how they can link to ICAN. Naomi's put in the chat box as well that it's already happening up in Merseyside, and it looks like it offers benefits. So I don't know, Ruth, I mean, is there any way that we can integrate the fire services? You talked about EMAS, but fire services more generally.
Absolutely, yes. I'd be delighted to pick that up and then bring that into our future work. It's a great idea.
Okay, that's fantastic. Thank you. Any other final comments from colleagues? So we can circulate the slides.
Nick, I had my hand up.
Sorry, Matt.
Sorry,
Matt. Please.
Yeah. I just wanted to say I think this is a brilliant piece of work, and I'm really supportive of it. And what gets me sort of excited in a nerdy way as an elected member is the community bit. And I think Ruth mentioned it as a difficult concept, and I would actually suggest I think it's quite simple, really. What we're trying to achieve there is having these services embedded in the community. But I think the challenge for me, and forgive me for using this example, and I've said it a few times at the Health and Wellbeing Board, I'm on Duston Parish Council, which is, Duston is the size of a small town, 15,000 people there, and it is full of small community groups, local services that can add a massive amount of value to what the system is trying to achieve. And I think the challenge for us all, and I've had meetings with Anna Earnshaw and Katie Brown, is to gather up all those services that are already there in the communities and link that into what you've just explained there, Ruth. So that adds, I can clearly see it could add a huge amount of value to what we're trying to achieve in terms of keeping people out of hospital, out of the whole system and everything else. And we've actually got a piece of work going in Duston where we've put a survey out, and we're trying to pull in all the data from all these different groups, and we're going to call it the Duston Together offer. That should hopefully capture all of these things, where we can host it on a website and have leaflets go out to people to say, look, this is what's here. If you need to access any of these, please come here. And then if you need anything bigger and further and more complex, perhaps we can direct that on to the community hub, because we've had a bit of a pilot there in Duston. But I think it's brilliant, and I think the challenge is to really make it more integrated into the communities. And I can see that it will add a huge amount of value. Thank you, Chair.
Yeah. Thank you, Matt. There's a comment from Russell here. Talk to Vin about our Happy at Home service. We can easily link to the fire service. I guess that's something which, again, Ruth, can you take some of these comments offline?
Yes,
Yep.
of course. And if anyone wants to get in touch with me, very happy to talk or come and talk to groups. So please feel absolutely free to contact me. Jo, did you want to come in on that?
Yeah, just had a final comment, just a bit of a plug for MyDOS. So obviously we have got the Northamptonshire Directory of Services. What I would say is please don't replicate everything in every area, because I think there are some services, and I would very much encourage organisations to get themselves listed on MyDOS. I think those community networks are absolutely key. There's no substitute for word of mouth. Someone in a friendly capacity recommending a particular service, that needs to carry on as well and link to people that you know. But I think it's also about making sure that these organisations are recognised, that they are listed. So I'm sure we can give more details of MyDOS for those people who haven't seen it. But it is really important that there are directory of services. People know where it is. It is one that works for all of Northamptonshire. And you're absolutely right. It's really hard to know what is out there. The other thing is the social prescribing link workers are linked into those organisations. They will flag them, check them, promote them. They are going to be some of the glue that's within our system. And again, we'll speak with local groups as well. And it fits really well with the area that Lucy was describing earlier, with our whole approach to social prescribing, much though many of us may hate the term. It's the one we're left with, but it is about that connecting people with communities. But I would say have a look at MyDOS. If you haven't looked at it, have a look, but I would absolutely recommend it to those organisations, to make sure that people know all about all the fantastic services. We have got amazing groups that are doing fantastic work, particularly in the context of COVID, and we just need to know what they're doing. So thank you to everybody for what you're doing, and for those groups as well.
Thank you, Jo. It's really well put. I mean, we'll move on to the next item now. There's obviously, I think there's a synergy between both. Two just quick comments from me, really. And as somebody who's outside the system, it does strike me as odd that sometimes people don't know within the system what services are available. Right? And I guess maybe, Jo, you've answered that, because there's just so much stuff. It's probably impossible to know everything that's going on. So is there a kind of a one-stop shop approach that we should be taking in all of this? So there is the information readily to hand for staff in the health service. The second thing is there a risk averseness here in the system? So, patients being kept in hospital perhaps longer than they should be, just because that feels to be the right thing to do by the staff. I don't know, but I think there may be a cultural dimension to some of this as well that might be quite challenging if that's the case. Finally, how does this link to the next agenda, which is the ICS? So that's a question in my head. let's find out. So the next item 11, is integrated care system plan. These plans are a national requirement for all areas of the country to have an ICS in place from April 2021 this year. So, well, thanking Sam and Joe and Ruth for the last presentation, can I invite Alison Gilbert, Director Lead NHCP Transformation Delivery at Northamptonshire CCG, to give us an update. And I think, Alison, this is the document, isn't it, that you're referring to? You can't see it on my fancy screen. Got a bit of out here. Final version 2.9.
Yes, indeed. Nick, could I introduce Naomi Eisenstadt? She's just going to, she's the chair of the partnership board. So I'll just hand it over to Naomi, and then I'm going to move into the detail of the plan. Thank you.
Of course, thank you. And welcome, Naomi. Welcome to your first Health and Wellbeing Board meeting at Northamptonshire.
My first, and probably the last, because there will be 2 Health and Well Board groups for each of the authorities. And thank you very much. Just very quickly to say, we have submitted the plan. We submitted it on the 23rd of December. It was due on Christmas Eve. And we've had report back from Region that it's a good plan. It's excellent. We'll see in the papers. I suppose what I want to say is something about, first of all, I want to thank everyone who participated and helped us with the plan. I particularly want to thank Lucy, because we had a development session in December to help us think through what we needed to do and what our clear vision was. And Lucy, at the very last minute, was asked to produce the data to back the plan, because I thought that we needed really to understand what's the nature of the population of Northamptonshire, what are the key problems, what do we know about which groups. And Lucy was extremely helpful in that, with very little time and handling all the other things she's doing. So thank Lucy and her team for that. I suppose a couple of things I want to mention. One is that we agreed at the session in December that the 4 priorities that had been identified based on the data and based on people's experience were still the 4 priorities for the future for the Health and Care Partnership. And they are frail elderly, elective care, children and young people, and mental health. Now, Krishni will know that we've made enormous progress on mental health, and you've just heard that we've made enormous progress on frail elderly through the ICAN program. I would say our big priorities now are children and young people and elective care. And I just want to make a comment. I didn't do it when Colin was talking about the Children's Trust, because I think it is really important that on children and young people, we don't forget that there's a lot of children and young people services that are not part of children's social care and are part of the things children need, like maternity services, postnatal services, early years services, schools. I mean, it really interests me that I never hear anything about schools anywhere. And that, that's children's service. They are children, they are pupils. Just like we call everybody patients, they call everybody pupils, but in fact, they are children. So those are the sorts of issues that I've picked up in this new job. And I apologize if not shared, but those are the issues that I've picked up in terms of our 4 priorities. Massive progress on 2, and I think quite limited progress on 2. And what we're going to ask at the next board meeting next week is for the groups responsible to begin to think about, in the discussion on BCF, we had a clear data on what we're trying to do and whether we're managing to do it. There were clear indicators of moving towards our goals. I think we need clear indicators of moving towards our goals on children and on elective care to figure out, well, what are our goals? And clearly that's a very, that is not an NHS task. That is a whole systems task. It's not just NHS and statutory agencies. It's a whole system task, including the voluntary sector and the community sector, and schools themselves, which of course, if they're academies, don't have the clear link to local government. So it's very, very important, I think, that we look at the whole system. I just want to comment on the paper that you've also had on as an index, which is the Integrated Care Next Step paper from NHS England. That again, I strongly advise you to read it, because I have to say I loved the paper, and I loved the paper because it had 4 key goals. And its first goal was improving health for all. The second goal was reducing health inequalities. And that's extremely difficult and incredibly important for Northamptonshire, because while Northamptonshire isn't particularly poor, it has enormous inequalities in health and education and social outcomes because it has very rich people and very poor people. So the band, the width in terms of inequalities on Northamptonshire is very, very wide. So the fact that the government is asking us to reduce health inequalities is really positive. And they're also asking us to manage our finances, which is really difficult. But the fourth thing they're asking us as a system is to contribute to the wider economic and social well-being of our area. Now, I consider that we're incredibly lucky to have 2 new unitary authorities just emerging, because it gives us a very clear area. And it also means that things aren't set in stone. Speaking to the chief executives of the local authorities, they're very keen to do things in new ways and to try out new ways. And it's easier to try out new ways when you're just setting up. So that to me is very exciting. And the other thing that's exciting within the Health and Wellbeing Board is within local government, if we really do want to work together to improve the social and economic development of communities, that means housing, transport, education, and employment. So it's things that are much wider and out with NHS, but very squarely within local government. And I think we need to consider those things in the way that a Health and Wellbeing Board and the 2 Health and Wellbeing Boards work with our Health and Care Partnership. So that's kind of my initial impressions. It gives you a sense of what I'm passionate about. And I'll hand over to Ali to do the detail of all these things we have to do next. Thank you.
Great. Thanks, Naomi.
Thank you, Naomi. So I think we've set the scene fantastically there, so very much appreciated. So can I just take us through the plan? So just for some context, this plan has been submitted to regional NHS colleagues, which was the national ask. So they are currently formally reviewing it, but we have had the feedback that Naomi described. So there's 2 sections to the papers that have been presented today. So there is still a step to go through with the national sign-off, but this is just the start. It's just to get us off the starting point for an integrated care system. That does not mean that we are going to be a fully fledged, fantastically functioning integrated care system as of April. It will be a step into our journey. And there have been a set of minimal requirements that we've had to achieve to get to that point. And I do want to thank all the statutory boards and the engagement we've had with local authority and providers, because this plan has been evolving and developing over months in the middle of the pandemic. So what you have in front of you is that final submission, but it will evolve. And we have been asked to provide more information, particularly on our financial planning as we move forward. And they very much want to see how we are looking at the overall collective approach to financial planning and control totals for the system and how we use our money and the value for money for our population. So they've asked for more detail on that, and they've also asked for more detail, which is in section 2 of the plan, of what we've already achieved, but they want to know, well, how are we going to do the next levels of development, and what are we going to achieve between now and April, and then as we move forward. So it's a continuum of a development of a plan, I suppose, is my message around that. The words that region have used, which are quite rare from an NHS perspective, is that it's excellent, it's compelling, and it's comprehensive, is the feedback that we've had formally. So, and we mustn't rest on our laurels on that. That is great feedback, and it is probably a reflection of absolutely where we've got to as a system. But sometimes when you get the really positive feedback, you think, right, hey, we're here, but that's just going to be our starting point. So I wasn't going to step through every section, Nick, but in essence, what the plan is describing is the system commitment, and there is a letter which we have also submitted to Health and Wellbeing Board, which shows the senior leaders and their commitment and the way forward as Naomi's described. The next section of the plan is, well, what is it? What's the problem we're trying to solve in terms of the health and care of our population, which resonates with the conversation with Lucy, and Lucy is the public health contribution. Then we move into the detail of the plan, so what we've achieved and the way forward. And again, you can see the complexity, and it moves from our transformation programs, which we've already experienced some of that around ICANN and some of the presentations today, but also the governance, the integrated governance and the architecture, and how we develop the function and how we embed programs like ICANN at all levels of place. We've talked about the communities, we've talked about the whole system, the whole population, talked about primary care networks, we've talked about community hubs, boroughs, districts, unitaries. All of this needs to be rewired and connected and move in the same direction to health, to improve the health of our population as we progress over the next few years. And in essence, that's what the final section of the plan is describing. Naomi's mentioned that we also have the national engagement. That engagement has closed that process on the 8th of January. And it is, I suppose, the key thing there is that the ICS developments within Northamptonshire possibly could be embedded within legislation on a national basis. So at the moment, this is not a statutory body, but the direction of travel is that it progresses in some shape or form into that space, and that's what that engagement piece is very much about. So just really to close, that the significant amount of work, I think it's really good to see that level of detail of our Northamptonshire plan, and I would encourage members of the Health and Wellbeing Board to use the detail of that plan and to share with their colleagues and their organisations, and the communication around it. And again, the message that this is a foundation, as a starting point for us. So the paper is to note, and I suppose the final thing for me really, Nick, is that this is it's a moment in time, a once in a lifetime opportunity that we have with the development, particularly of the unitaries. And we also have a single CCG, we have our group models, we have the work that's been described around the community resilience, COVID, and Northamptonshire is in a relatively unique position with that. That is not the same for a lot of systems, not just within the Midlands, but across the patch nationally. So we need to grab this, even though we're under a lot of pressure at the moment. So the plan is to give everyone a bit of clarity and optimism for the future. And so that's all I have to say today. And Naomi and I'm happy to take any questions. Thank you very much.
Thank you, Naomi. Thank you, Alison. It's fantastic. Congratulations! What an excellent report. Great, really hitting the ground running on this one, Naomi. Matt, you've got your hand up, please.
Sorry, it was a legacy hand, but I will just echo your comments, Nick. It's an excellent piece of work, and we are at a moment in time, and we've really got to pick this up and run with it. And I'm sure certainly politicians that may be involved in the future, recognise that, and we've got to really push this and make it work for everybody in Northamptonshire. Thank you.
Yeah, thank you. Any other questions for Alison or for Naomi? I mean, the one I have is actually you've answered it on page 45 of the document, where you've integrated back to the previous discussion about ICANN, because it would be odd, wouldn't it, if these two documents didn't cross-reference each other in any integrated way, and they do. I guess my only rather pedantic comment is that you seem to have the wrong version of the house on page 45. I don't know. Maybe Ruth, you could quickly scan over that and just make sure that it's the most recent, up-to-date version of ICANN. But it's great to see that as part of the solution that we're trying to work towards. Any other comments for Alison or Naomi? I can't see anything in the chats, no hands, real or legacy. The board's asked to do a number of things, to note the contents, which we will do, and the signed letter of support to be progressed by April 2021. To note the ICS designation next steps, to note the NHSEI feedback, which sounds incredible. I mean, the way that just the words being used do sound incredibly flattering. So congratulations. To note the NHSI integrated care next steps, etc. There's a rather technical thing to note about a paragraph 1.51. I'm sure that means something to someone. And then finally, for commitment and support to Northamptonshire's ICS development. So yes, the board is asked to do those things, and we have done them. So thank you very much indeed. Let's move on then. Item 12 is KGH HIP2 program. So I'd like to invite Polly Grimmett, Director of Strategy and other things at KGH, to present an update of the redevelopment work taking place at KGH.
Thanks,
Polly.
Nick. I'm going to start that one just to...
Oh, sorry, Alan.
Polly, that's okay. Thank you for the opportunity to talk about this. We have presented this to most of your organisations before in one form or another. So it's a bit of a canter. The timetabling shows us as 20 minutes for this. So we will be going at a bit of a canter here to get through it. And just echoing your point, Nick, it would have been strange if the ICS had not echoed the ICAN programme. It would be strange if our redevelopment plans for Kettering didn't reference the ICAN programme. So these things rapidly become literally bricks and mortar. And that makes it very important we get it right, because if we make a mistake with this kind of development, then it lasts for a very long time. So we're going to take you quickly through the government decisions that sat behind that. And I just make the point really that we had applied for a long time for money to rebuild our emergency department, and we knew exactly what we were going to do there. We had not applied for money to rebuild the hospital. So when they announced that we were going to get a new hospital, we didn't actually know what we were going to do. And it has taken a great deal of work led by Polly to get us to the point we're at today. So we're going to kind of go through our decision, what we did. We're going to go through the decision-making process, and we'll go through the plan that is or will be submitted to our regulators as part of the next step of approval. So Polly, over to you, please. You are the SRO for this, you're the expert, and you've done an excellent job getting us where we are today. So over to you.
Thanks very much, Alan. Hello, everyone. For those that don't know me, I'm Polly Grimmett. I'm Director of Strategy at Kettering General. And as Alan says, the SRO for this, for the redevelopment. Please, may I have the next slide? I will go, there are quite a few slides here, so I will go through them fairly quickly so that we do have some time for some questions and answers at the end. But basically, as Alan says, back in September 2019, so over a year ago, we were announced as part of the government's HIP schemes. So there were 40 of us, 40 new hospital projects. And in October as well, that was reconfirmed by the Prime Minister that we would be getting some money. So initially what we've had this year to spend is some seed money. So we got a couple of £1 million to spend this year on looking at the strategic options for what a redevelopment of Kettering Hospital might look like. If I could go on to the next slide, please. So what have we been doing over the last year? So basically we appointed a team of very experienced individuals and consultancy firms who got vast amounts of national and international experience of building hospitals on complex, difficult sites. So we appointed them. We've been engaging extensively with stakeholders across the trust. So we have a clinical cabinet that leads this. All of our clinical teams have been engaged. Our staff engagement events had over 500 different comments and ideas about what our staff felt they needed to be able to deliver improved patient care. We've also run public engagement events. Some of you may have been at those and been out to system groups and all sorts of different groups. So we've got a wealth of information now about what our patients, our public and our staff feel are the most important things that we need to focus on this redevelopment. And what I'm going to take you through, if I could go to the next slide, please. What I'm going to take you through is the result of that, if you like. But just in terms of assurance, this is some of our population modelling. So there's a whole amount of population modelling in the strategic outline case. You can see here, we're on that graph, we're at year 0, obviously, and we have, this is inpatient beds. We have just over 600 inpatient beds at the moment, and that's in the light blue. In the dark blue down at the bottom, you can see the number of beds that are currently being taken up by patients who don't really need to be in an acute hospital. And I think on the agenda, you've already had the ICAN work, and obviously we as an organisation, as well as the rest of the system, have signed up to that. And that's the impact that we will have through that work. So you can see in terms of our population growth over the next 15 years, the number, if we did nothing, that's the light blue line, aside from what we're doing now, then we would need over 1,000 beds to build in our hospital. And that's a huge amount of beds for a population the size of Kettering. And obviously that would be very expensive. So we've overlaid some assumptions on that about clinical efficiencies that we can get out of the hospital from patients who need to be here through having new buildings. So we can, by co-locating care, at the moment our buildings are spread really quite widely across the site, but by being able to build and co-locate that into single buildings, it will be able to improve our length of stay and our efficiencies of the way we're treating patients. So you can see some of that modelling and the impact that that has on this graph. And I think really the assurance that I'd kind of like to give you here is we've absolutely factored in the ICAN. We're signed up to it as a board and as an exec team. We are fully behind ICAN and putting a lot of efforts into it. So our forecast of the number of beds that we need for the new hospital is dependent on ICAN working. So that shows the commitment that this trust is making towards that piece of work. So could I go on to the next slide, please? Thank you. So what I'm going to take you through now is the end of last year, we as a trust board agreed to a development control plan for the site. So that is a trust-wide long-term plan for how we might redevelop Kettering Hospital. The first thing we needed to establish is, could you even redevelop Kettering Hospital on the current site? Because we don't have that much empty space, as people that know the site will know. However, we did establish fairly early on in the process that we could do that. So therefore, we looked at a series of options at Trust Board as to what that might look like, and we agreed those at the back end of last year. So I'm going to take you through what that looks like in terms of the redevelopment, and I will then take you through the different options that our board considered. So yes, please, next slide. I can see the cursor hovering. So flick over to the next slide and I'll take you through some of the diagrams. So this is our current hospital site, and these are the buildings on it. You can see on the right hand side you've got Rothwell Road. So top right hand side of this picture is the A14, and the Rothwell Road is where we dip down the hill, and you've got Kettering, obviously town centre to the other side of that. So that you can see here how geographically spread out our hospital buildings are. And at the front end you've got buildings that we're still using that are over 100 years old. So if we could move on, please. This is the future vision of what our hospital is going to look like by the time we have redeveloped the whole thing. So you can see there you've got some 4 or 5 big new blocks in the middle of the site. Those older buildings at the front of the site will get demolished and cleared to be able for this purple line shows the patient and visitor drop-off zones. So at the moment we have car parks that are randomly placed just where we have spare space at the moment, but this really brings it all together, so patients will be able to get access directly into the hospital buildings that they need to be in, so cut down on their journey times in and around the buildings. It also shows, as I say, co-location of clinical services and our staff and our teams into a much smaller number of buildings, which will enable our patients to get access to the care they need faster and allow us to bring some staffing efficiencies. I think the other thing that we really wanted to do with the redevelopment is create lots more green space. So I think in terms of health and well-being, both of our staff and of our recovering patients, it's really important now, and it's obviously nationally and internationally recognised. Having access to green space and natural light and fresh air is key to that. So this site redevelopment plan really does focus on that. Thank you. Next slide. I feel a little bit like Chris Whitty. So these are some images of what our new buildings might look like. So the one at the bottom there is the site entry. That's what I just described. Currently, that's looking from the other side of the Rothwell Road at what the new buildings will look like, top of the hill being on the right-hand side of that image. And the first building, phase 1, that I'll talk about in a moment, is going to be our new urgent care hub. And you can see that image there on the top picture. And again, please. Okay, So this is our current hospital site. Shaded in light grey are all of the current buildings that we have. In dark grey are the only 2 buildings that we plan to keep. So building number 1 there is the foundation wing. That's currently where we have our ITU, our paediatric ward, Skylark, and our cardiology centre. So that's in building 1. These 2 buildings are less than 10 years old, so we're not seeking to replace them. The second building there that you can see is the treatment centre. So we will be keeping those buildings. And then as phase 1 of our redevelopment plan, next slide, please. You can see here, the next dark grey buildings, there are 2 of them. The one on the right-hand side, the smaller one, which is down at the bottom of the hill, is a new energy centre. So Kettering Hospital is reliant at the moment on temporary energy facilities. And we know that if we're going to build any new buildings, we need to replace our energy centre. It also ties into our ambition to be net carbon zero and be a really sustainable hospital. So that will be the first building that we build, but it's not that sexy, is it, to build an energy centre? So we've then got the first phase, which is the bigger block on the left-hand side, and that's our new urgent care hub. So on the ground floor, that will have an integrated A&E department. We will then have on the floors above integrated assessment units. These include mental health facilities, opportunities for primary care to work with us in those areas, and community services. There will then be the urgent care wards above that. So that's a 6-storey building. We will have new ambulance routes in, and buildings such as where I'm sitting at the moment, Glebe House, will be demolished initially to make way for that building. So it will sit where I currently am and into Car Park A. Once we've built that, it will enable us in the light blue there, that's our outlined in light blue is our current A&E buildings. It will enable us to then demolish those because the services will have decanted into that new building. So this forms phase 1 of our work, and you can see there the cost of that at the moment is estimated to be 250 million to build that alone. Phase 2, if we go on to the next slide, please. You can see there then attaches onto that building. So that will contain a lot more of our inpatient wards. You can see that we will have new operating suites, endoscopy, pathology, those kind of clinical services will go in there. And by that point, really, we've replaced about 70% of our inpatient bed stock just by being much more efficient. That's another 6-storey building that will go up there. And by the time we've built that, then you can see that we can then knock down those ones that are outlined in light blue. The vast majority of the middle of our site will then be able to get knocked down because it would decant into that building. And by this point, we're costing that at 532 million. Phase 3. I'll speed up as I go because we're running out of time. So phase 3 then it really completes the vast majority then of our clinical services that will get moved into that building, and we're then at 765 million pounds. But that is 100% then of our patients on inpatient wards will be able to have the advantage of having new facilities as opposed to some of the really old buildings that our patients currently have to reside in. And then phase 5, I think, if we could flip again and just flip again, you can see the last final stages of the development. Really, they will be a long way in the future. They will be probably 10 years plus. So I won't talk too much about them at the moment. But by this point, we really start to get an integrated kind of health and wellbeing campus. Ideally, and I've spoken to some of our external partners and some of you about different services that we might want to bring onto this site that complement an acute setting. So they won't all be run by us, but whether or not we want to increase dementia facilities on this site, step down beds, there are all sorts of things that we're going to have started to look at and will continue to look at with our partners. So if we can carry on, please. Thank you. So I'm just going to very quickly run through the process our board went through. So it reviewed all of those options. Next slide, please. At our board meeting, we have to go through a very strict process. HM Treasury process is fairly set in stone for public sector. So we have to go. We went through that. We looked at our long list, which included all the phases you've seen there and a greenfield site. And if you carry on, please. So you can see there, we looked at 6 different long list options, and I've taken you through all of those different phases. Now, our development control plan will include all of those phases. What we went through is at this point in time, what is our strategic outline case for the redevelopment going to say? Is it going to ask for all of the money, which will cost over £1 billion, or are we going to go and be more sensible, I suppose, and go to a different phase at this point in time? But bear in mind, our trust has now signed up to the entirety of that development control plan. So if we move on, please. So these are the options that we looked at in some detail. You can see the different phases I've talked about are the columns across the top there. Some of the things that I've talked about in terms of the overall impact. So you can see here, business as usual, if we did nothing, only 20% of our estate is currently rated in condition A and B, which is good standard of estate and what nationally the NHS considers appropriate for clinical care. So that is 80% of our current buildings are rated as inappropriate for modern standards of clinical care. So you can see there by phase 1, we then improve that to 43%, 76%, 83%. You can see that going through. I won't spend some time going through that. You can see here at some of the rows at the bottom there, the total capital amounts that I took you through. So phase 1, 250 million, 532, and going up, you can see there down in bold. So phase 5, as I say, would cost over £1 billion. If we were to go to a greenfield site, and we did consider that option because there was a greenfield site locally that we could consider, that would cost even more money. That would cost 1.3 billion. Reason for that is that, number one, we wouldn't be able to keep those 2 newer buildings, so we would need to reprovide the whole of the estate. Number 2, that we would have to put in electricity, utilities, waters, all those kind of things that we currently have on this hospital site. That's why that is more money. I think the other key thing to just point out is the revenue impact, estimated revenue impact, which is the second to bottom line. Capital, unfortunately, from HM Treasury isn't free. So we will have to pay back a PDC charge of 3.5%. That's an annual charge. So one of the things board really spent a lot of time talking about is what could we afford to pay back? So not just what did we want for our for our capital amounts, that what we wanted to appeal for, but actually what could we really afford to pay back without impacting on patient care? Because you can see by the time we get up to phase 5, that's £52 million the hospital and the system would need to find every single year to pay back to HM Treasury. So when we go on to the next slide, I can show you, please, thank you. I can show you that because of that, this was our long list and what we rated. Because of those annual payback charges, the trust board agreed that it couldn't commit and it wouldn't ask for a rebuild, 1.3 billion on a new hospital site, or indeed phase 5 of the redevelopment, principally because we would have shiny new buildings and we wouldn't be able to afford to staff them or run any clinical services out of them. So we will certainly be applying for phase 5 in later funding rounds, but at the moment we wouldn't apply for that. Obviously, business as usual, we certainly wouldn't want to accept that. So our trust board agreed that phase 3 of the redevelopment that I took you through is what our strategic outline case will list as its preferred option. So that was the £765 million benefit, and that's where really the vast majority of our patients at that point will get care delivered from new facilities. So in terms of where we are, and I'll just close off with this. So this is here for your information, so you're aware of our progress and what our trust board has agreed as its preferred option for redeveloping Kettering Hospital. We are in the process now of finishing off our strategic outline case, but you've seen the meaty bit of the strategic outline case. Our strategic outline case will be coming to our trust board at the end of February. It will also be coming back to this board and the CCG board because we will ask for letters of approval and support that the system supports this redevelopment for the north of the county, supports the fact that we will be working with partners. These won't just be acute buildings. That's not the world that we live in anymore. So the next phase of our work, which will kick off after that approval in February, so in the spring and summer of this year, we'll be absolutely engaging with all of our system partners to find out what are the services that we think we can do together in these buildings that will be for the benefit of our patients. And I'll probably stop there because that's the vast majority of these slides. Thank you very much. Happy to take any questions or hand back over to Alan for any closing comments.
Thanks, Polly. And I think that's, as I said at the start, a pretty quick canter through what was a major set of what I tend to refer to as big brain problems, really. There's been a lot of thinking gone into how this might work. And as you can see, it's a difficult balancing act between what we think we can get from the government, what we'd like to get, what we can afford to repay, and the kind of balanced, integrated, coherent service we want to talk about. And it does resonate with everything we've talked about today. It's got a heavy reliance on digital, both in its design and its operation, but also in its capacity to think about out-of-hospital care and digital monitoring of patients and the stuff that goes with that. It links very much to the ICAN project and other programs. So it's very definitely a proposal that sits within the Health and Social Care Partnership framework. Very happy to take any questions, Nick, or comments.
Great, thank you, Alan. Thank you, Polly. Excellent presentation and really exciting development. Any questions for Polly or for Alan? I've got a quick one. It's how on earth can the Treasury ask for 3.2% return when interest rates are negative? Shall I stop there? You don't need to answer that. It's a rhetorical question.
Yeah, okay.
Well, I mean, there is an answer there a little bit. There has been debate.
I knew he couldn't resist. I knew he couldn't resist.
No. I mean, I agree. The Treasury can do that because the Treasury is really greedy. I mean, it's really that simple.
Yeah, exactly.
But there has been a debate that if the government is investing in 40 million new hospitals, then that rate of return will make it very difficult for 40 NHS trusts to develop a coherent building plan. And so there is an argument going on further up the system than we are about whether that is the appropriate rate to run. It's not for us to prejudge that. That is the rate at the moment, and that's what shaped our decisions.
Yeah, thank you, Alan. Other comments? It's kind of watch this space. I mean, the board's asked to do a couple of things. This is reporting in, so to support the development and its intention to continue on the existing site, I think absolutely. Note the growth assumptions adopted in the sizing in the future hospital, yes, and support Kettering Hospital in its submission of a strategic outline business case and its choice of preferred option. So I think absolutely board approve and wish you well in your endeavours. Thank you.
Many thanks. Thank you.
Yep.
Right, let's move on. Item 13 is the COVID-19 update. Various folk involved. Lucy, apologies from Toby. So I don't know whether Joe or others can update on the mass vaccination piece. I think Councillor Morris has would like to say something as well. Lucy, can I hand over to you, please, for this item?
Of course. And apologies, I know a lot of people do get updates in other forums as well. So I will make this brief. Obviously, a lot of data from point of view of rates, etc., is now available on the Gov website, so freely available to the public. But if I just give you a quick summary of the headlines, she says, trying to pull up the most recent data. So literally today's report. So this is data that goes up to the 8th of January. Overall, it's a pretty bleak picture, unfortunately, and remains so. And that's not unique to Northamptonshire by any stretch of the imagination, but certainly in the East Midlands, we do seem to be battling more of the new variant, and therefore that is translating into much higher positivity rates and case rates. At the moment, our positivity rate, so that's the proportion of tests that are undertaken that turn positive as a weekly average, is 19.7 in Corby, so that's the highest positivity rate, and it varies considerably down to 10.5% in East Northants. So we do have quite different and variable rates across the boroughs and districts here, and obviously lockdown is helping facilitate those areas that are lower, staying lower. And that's the reason that it's so important that people comply, so we don't end up with the whole county in as difficult a position as we're currently seeing some of our boroughs and districts. Northampton close behind that at 19.3% positivity. The one bit that's really positive is people are still seeking testing, and that is so important. The only way we are ever going to get on top of this, as we know from previous experience, is making sure that people get tested if they have concerns, if been exposed, or indeed obviously are developing symptoms, and they need to be isolating until they get those results, and then following government guidelines thereafter if they are positive, along with their household members. We are seeing, obviously, because of that positivity rate and an increase in our case rates. And at the moment, apologies, I've got somebody knocking on my door. And our case rates at the moment, unfortunately, in most areas are still on an upward trajectory. The real concern is the over 60s, who are currently obviously translating quite heavily into admissions and very sadly in some cases deaths. And again, we've still got an upward rate there in our over 60s. Case rate and big cause for concern around compliance is the 17 to 21-year-olds. We do obviously have a high rate there, and at the moment, for example, our 17 to 21-year-old rate is 1,223.8, for example, in Corby, 1,436.3 in Northampton. So a significant concern, and really we need to be reflecting on, are we getting the messages through to that younger population so that we can get those case rates down. Those people at that age are quite often living obviously in wider households, and therefore that household transmission is still our biggest issue, although you can see obviously that our outbreaks are increasing as well. But member to member transmission within a household, and still despite lockdown, household transmission is still by far the biggest route for transmission locally. We have got to adhere to the rules. We've got to break those chains of infection. If I stop there and just see if there are any questions about rates and cases for the time being.
Thank you, Lucy. As you said, lots of people get the information. It's a great, there's a lot of stuff out there on the web now, locally and nationally. So very helpful.
If I add just at the moment, it's probably easy just to give a very quick update. I know we've got colleagues from our acute trusts online as well, but as I said, that pressure on the acutes is significant and will remain so until we see our overall case rates reduce. We will not start to see, and there will be a significant delay in that impact being felt in the acutes. We will not get back on top of the provision that we need to and get that capacity back in our health and social care system. And that's not just our hospital beds, although I will talk about those in a bit more detail. It's primary care that are feeling this pressure, and adult social care too. So at the moment, to give people an idea, the 2 hospitals in our trusts have by far the highest number of admissions that they have ever had that are COVID positive, including during the first wave. We currently have 422 COVID positive patients across the 2 trusts. That is nearly 40% of our beds taken up by COVID positive patients. That clearly means that there is pressure on our ability to maintain any other services. And it also means that translates quite often into beds not being available, because those positive patients need to be cohorted in such a way that they don't pose a risk to the other patients within the hospital. So it reduces our overall bed availability. And then there's also the risk to staff. And we are clearly regularly testing staff, but because we've got such a high proportion of COVID in our hospitals, we are also seeing that translate into pressure on staffing as well, as people have to isolate if they're exposed or indeed have a positive test. So, we still have, with increasing case rates, we have still got a significant pressure on the acutes, and that is quite likely to get worse before it gets better. But again, compliance is key here. If we can get people to do as they're required to do, we can get trends down, then we will start to see pressure relieved on those services too.
Okay, thank you, Lucy.
Would it be helpful if I said something now, Nick, as well?
Yes, please, Alan. Yes.
Lucy's comments. The numbers of cases are rising quickly, and we don't expect to reach the peak of those numbers till into next month. The patients coming into hospital and patient deaths are kind of baked in now. Those people are infected, and this is what's going to happen. It's really that simple. We are currently being asked to surge our ITU capacity to 200% of what we were. And whilst people will have heard about shortages of oxygen, I just perhaps might helpfully clarify that, but it's not a shortage of oxygen, it's the difficulty of pipework sustaining a level of demand which we've never expected to meet before. Kettering's actually in a rather better place by accident for that than Northampton is. And of course, this is nervous stuff. So our monitoring of those oxygen consumption levels are constant, because if it goes wrong and the oxygen freezes at some point in the pipework, that is quite a catastrophic failure. So you can be assured that we're not short of oxygen when we are monitoring very carefully our oxygen demands on these patients. And of course, the other thing to note perhaps is we have slightly fewer patients in ITU as a percentage this time around, which is arguably a good thing. But the byproduct of that is this massive oxygen consumption through what are called CPAP machines in our normal wards and areas. And of course, as Lucy says, it's over 40% of our beds, but we have lost beds as a result of needing to have distancing between our beds. But we've also, we've got an added complication in where we can put our patients. We used to think about medicine and surgery and age and male and female, and now we throw in COVID or non-COVID, since you can't really mix the two together. We have plans for finding more adult bed space, which will involve probably some centralising of some services in one or other of our hospitals to create that kind of space. And we'll be doing that if we have to, as a simple, an urgent operational decision. But there comes a point, of course, where we don't have plans because there is no plan. And at that point, it will become very, very difficult. And we have, as everybody knows, having lots of conversations with partners in social care and in nursing homes, because we probably do have about 80 patients who shouldn't be with us at the moment and who could be moved, but there are all sorts of complicated reasons behind why that's difficult. So the conversations are very productive, but haven't yet produced, if you see what I mean. So the pressures are very real on us and on our staff. I was deeply saddened, really. I'm not a great social media animal, but I was looking at some social media stuff over the weekend, and we've got staff posting messages which are basically saying, "I'm broken." And that's a really bad place to be. We've got staff who've been going through this now for 10 months. And whilst we have been insisting on holidays as best we can, there has not really been a break in this process for some of our P staff. So if we can get a message out to people that this is real and we do have broken staff, and that's not a place you would wish your health or your social care service to be. Thanks.
Okay, thanks, Alan.
I don't know if Dr. Watt would like to add something about obviously the plans and the rollout of vaccination. Clearly, as we've reinforced, I think a number of times, this is not a silver bullet, but it certainly is a ray of light, a sort of a spot of light at the end of the tunnel. As Alan quite rightly says, we've got a really challenging couple of months where pressure will no doubt increase rather than decrease. But vaccination obviously is one of the ways that we are going to be able to move forward. So I don't know if we can hand over to Joe, Nick, if you're happy, just to give a bit of an update there.
Yes, please. Thank you, Joe, if you're willing.
Yes, thank you. So I think vaccination is, as I say, a small ray of hope. I would urge people that even once people are vaccinated, it does not mean you can stop doing all of the things we need to do. Hands, face, space, be tested if you have symptoms. It doesn't stop any of that. So it is really important to say this is the beginning of our way out of this. But we're not out of it yet. So just would urge people. I think the other thing that's really important is to say to people that you will be called when you are eligible. Please do not call your GP surgery. Please do not call the hospitals. We are working down the cohorts as defined by the Joint Committee on Vaccination and Immunisation, and we are working down with through the priority lists. The reason those are in the particular cohorts they're in is it is the best way to save the most lives. And so we're starting with cohorts 1 and 2. Cohort 1 is care homes, residents and staff. Cohort 2 is over 80s and health and care workers. And as the vaccine comes more and more into our county, we will be working down all the other priority groups. Those groups are available in the public domain, and we will call people or text people as they are eligible. If you are a health and care worker, that will be organised through your occupational health department. And we have a number of different facilities and options for people within the county. So we have the primary care networks, have settings in all of the districts and boroughs, and those will be settings that are relatively close to the population of Northamptonshire. And so as vaccine becomes available, people may be called to those, but very much as the supplies become available, people will be called. And so there will still be some people in those two groups who have not yet been invited. The hospital trusts are also vaccinating staff, and we will also have a mass vaccination site that will be coming online later on in the county as well. So there are a number of different venues that are available. I would like to make people aware of there are some scams, unfortunately, out there. And the NHS will never ask you to reveal your bank details or ask you to pay any money. So please be really careful if you receive a text of that nature. That is not from the NHS, and obviously does need to be reported from a fraud point of view. If you get communication from the NHS through that method, it will not be asking for any of those details. But certainly those groups will be getting contacts, they will be getting those vaccines, and then they will also, after their first vaccine, they will then be offered a second vaccination in approximately 12 weeks' time, in order to make sure that they receive both doses of those vaccines. We have roving teams who will be going out to make sure that care home residents are vaccinated as well. Really important, they are an extremely vulnerable group. And so we will make sure that everybody is offered that vaccine to get that protection. But as I say, I would reiterate, please don't stop doing any of those things, even if you've had a vaccination. It is really important that we get everybody covered, and we will be working down those cohorts as quickly as we possibly can. But please don't block the phone lines of your local health providers. There are some really poorly people trying to get through. So thank you for everybody who's being really patient. Appreciate it's really frustrating. People are desperate to be vaccinated, and it is a wonderful thing. And the staff that are doing it are working so hard. Would really just also like to say a really big thank you to everybody who has made vaccination possible. That's from the teams that have organised the management of it, the teams who are jabbing, nurses, healthcare assistants, doctors, pharmacists, everybody that's doing that, and also the community venues that have been offered. The volunteers have been absolutely amazing, the marshals, the car parking. It is a fantastic county-wide effort, and really want to thank everybody that's been involved. We are going to be doing this for months. So this is, as people have said nationally, a marathon, not a sprint. We have got months and months. We are going to make sure that everybody gets the protection that they need, and really just thank everybody who's been involved and everyone who's come forward to help this enormous effort. Thank you.
Thank you, Jo. Nick, shall I just very quickly, while we're on the subject of vaccinations, just give the headlines around flu as well? So clearly we're still in the middle of flu season as well, and it is just as important this year, even with social distancing, that people get their flu vaccination. That continues all the way through to March. So you can still have the opportunity to get your flu vaccination if you haven't done so yet, or indeed if you chose not to earlier, you are still and are still eligible, you can still get that vaccination. This year, it was rolled out to a couple more groups than normal. So school children in year 7, households of shielded people, and residents aged between 50 and 64. It's usually 65 and over, you see. From a point of view of actual uptake locally, I'm pleased to say that from the data that we do have, which is from the groups that are usually offered the vaccine, we don't have it for those 3 new groups yet, sadly, but for the groups that we do always offer the vaccine to, the over 65s, the under 65s who have a long-term condition or at risk, pregnant women, and 2- and 3-year-olds who have the nasal spray version, we have got an increased uptake in all of those eligible groups as compared to last year. In particular, pregnant women were sort of lagging behind previous years' uptake. I'm now pleased to say that that is now 2.4% above last year's uptake, but again, there's still more that we can do. You are still at risk despite all the additional measures that we're taking. So please, if you are eligible, I would still encourage you to get that flu vaccination. It's just another one of those tools that will protect you, protect the people around you, and hopefully also protect our adult social care and health and care services. So please do uptake if you're offered, but good news that we've started to get that rolled out, and it is indeed at a higher rate than previous years.
That's great. Thank you, Lucy. Well, thank you, colleagues, for a rather sobering update, but some light at the end of the tunnel with the vaccine. Can I ask a very ignorant medical question? I've had the flu vaccine. If you had the flu, can you catch flu and COVID at the same time?
So I think the first thing I would say with that is that the flu vaccine does not prevent all respiratory illnesses. So a lot of people who believe they have flu have a flu-like illness. So particularly people who believe the vaccine gives them the flu, usually it's just a coincidence. They picked up another flu-like illness. What I would say is anybody who has symptoms, please get a test. As a GP, I'm constantly speaking to people who go, oh, I've got a bit of a cough and a bit of a fever, it'll be flu. It may not be. I would just urge people, if you're not sure, please, in fact, anyone with any symptoms, please get a test. So please don't anybody make any assumptions that you have flu or COVID without getting a COVID test first. If you're thinking about buying cough medicine for anyone, get a COVID test. Really, really important to do that. And no, you wouldn't know it was that COVID cough. In response to the question that I'm often asked, I'd know if it was COVID. No, you wouldn't. Please get a test. So yes, there are always lots of respiratory illnesses. They're always circulating this time of year. Better due to social distancing and better hygiene this year. But I would absolutely urge people, if you think you might have any of those respiratory illnesses, please get a test. Those are really readily available at the moment. Lots of different options about how to get those. Or 119 if you're not certain, or obviously there's other options as well.
Brilliant.
Yeah, and as a very direct response, you can be infected by both, and it significantly increases your risk of a negative outcome. So either a very, very long-term illness that could have significant consequences from a point of view of your long-term well-being, or indeed it significantly increases mortality. So clearly, if you are offered that vaccination, please do take it up. The more protection you have, the better.
Yep. Okay. Thank you. Very wise words. Thanks, folks. Right. Last item for AOB is the future of the health and wellbeing forums. We brought a report, myself and Lucy, to the last meeting about the future of these groups and what happens to them post the 1st of April when we move into 2 health and wellbeing boards. They do add value, I feel. There's issues that Naomi was talking about previously to do with linking the community activities in schools, etc., general well-being and placemaking and community resilience. So I've been talking to David Smart about some of these issues. I feel that they add value, but what do we do with them? Lucy, can I sort of pass the challenge to you, because there are some options. One is that we just get rid of them. I don't think there's a statutory need to have these things baked into in stone, and yet they do add value. But I think we need to reorganise them around the new Health and Wellbeing Board boundaries and integrate them better into our decision making. But how we do that is not so straightforward. Lucy.
So I'm going to be very honest with everybody. As you say, Nick, there is no statutory requirement for the Health and Wellbeing for it. In fact, they weren't even actually developed at the request of the Health and Wellbeing Board initially. They evolved from a number of different community development groups and community safety partnerships and all sorts of things. But as you say, I do think they add value. They provide a forum for different partners who serve a geography to come together, share ideas, share information, but engagement is varied across those different forums, as we know. The challenge, I think, at the moment is, and I'll be, as I said, I'll be completely honest, we're still very much looking at what is safe and legal for the 2 unitary organisations. And as I said, the forums don't factor into a lot of those plans just simply because they're not part of the statutory makeup of any council. What I'm keen to do, and I apologise because I genuinely haven't had time to do it for obvious reasons until now, is pick this up with Naomi and Ali. We know that we're still developing, what the different geographies are and what place means for Northamptonshire, particularly in the levels underneath the new unitary authority footprints. So I think there's something about how we develop engagement generally and representation of different partners and different geographies in that new world that will form part of this. Now, I'm fully supportive that those forums continue to meet. They tend to be self-sustaining anyway. In the interim, as I said, we have no formal jurisdiction over what they do anyway. So I would encourage those people to continue to meet, particularly when it's a coalition of some really willing people who are very invested in the development of services for their local population. And Naomi and Ali and I can take that offline to see what we think might be beneficial and how we might be able to support that and factor it into the infrastructure going forward. And Nick, if I may just take the opportunity as well, and I look to Councillor Morris and also Ian, yourself, around local government reform. I think it's worth us mentioning now, our next meeting would be due to be June. Now, once upon a time, we'd expected local elections to be happening in May. And this week, quite a lot of doubt has been cast over that. So we had expected the 2 new health and wellbeing fora to have been approved through full council and for potentially new chairs to have been identified for those new meetings in June. It may well be that those local elections do not happen. We've yet to have that confirmed. Nick, I know we've spoken to you about, are you able just to help us hold the fort in the interim until those things become clearer? But it's just to make members aware today that we're not quite sure what form the next meeting will take, whether it will be a single one, 2 separate ones, and who the chair will be. But we will be meeting, and those plans obviously will be ongoing as soon as we get a bit more detail. I think, is that fair reflection, Councillor Morrison and Ian?
Yep, Ian's nodding. Yep, thank you. So just on that, just to maybe to wrap up, because we can finish quite early if I don't drone on. The idea that Naomi put forward about when the new 2 unitary 2 health and wellbeing boards start up, how they get things like school input, looking at things like employment, jobs. I think they're important aspects of healthy societies in general. I mean, look at the Northampton Town Centre. You can imagine what the impact on your health and well-being would be, your mental health, if it's just boarded up, you know, because all the jobs have gone. So this is an issue post-COVID that I think the fora, if we get the right flavour and the right people involved, could have a powerful impact into the sorts of issues that lie tangential perhaps to health and well-being, things like jobs, employment, volunteering and all the rest of it, but ultimately have a potentially big impact. So that would be my gut feeling about how, if we can be clever, we can get these fora, whatever they become, working more coherently, addressing some of the issues which aren't directly 100% health related, if that sort of makes sense, Lucy and Naomi. So I think that's where we could find the value.
Yeah, absolutely. I'll take that as an action to pick up with Naomi and Ali, and Naomi want to come in, but apologies, I've just been corrected. We do have a meeting in March, so hopefully we'll be able to give you an update about elections and bits and pieces, but I think it's something that we just need to be cognizant of, that clearly COVID is playing havoc with all of our plans, but we will make sure that we get the detail to you as soon as possible.
Okay, thank you for that. Right then, so any other business?
There's just a couple of hands up, Nick.
Yep, sure. Tansy.
Sorry, there's a paper going to the NHCP board next week, which is particularly looking at community activation through the patient and public voice. So totally agree with your summary just then, Nick. At the moment, because everything is so busy, we haven't really been able to engage with the 2 unitaries, but we do see that tying that in to some form of mechanism is going to be a very exciting opportunity of maximising community voice.
Yeah, okay, thanks. Thank you. Naomi and then Krishni.
Yeah, apologies for taking more time. I just want to say, in terms of my previous life, when I did I was in charge of a major piece of work on long-term outcomes for children and their parents. The 3 factors that were most deleterious for children are, basically poverty, poor housing, unemployment, and mother's mental health. So in terms of future costs, these are the things that will really be preventative if we got them right. And that's why you can't put everything together because the elephant's too big. You have to chunk stuff up in some way, but managing the joins is really important. And that's why, I don't think it's for the Health and Social Care Board, but I do think it's those wider issues where local government, voluntary sector, and health could work. And particularly local government and health will be the largest employers in the locality. So the role as employers in terms of paying a real living wage, in terms of recruiting from local people, and in terms of young people's employment, linking with colleges. I do lecture, but that's why I think the links are really important. They have very, very direct impact on long-term health and outcomes.
Yep, very well said. Thank you. Krishni.
Thank you, Chair. Hopefully you will have seen this already, but I just wanted to mention that Cheryl very kindly circulated a something on my behalf to members, which was just an event we're running on Monday. Several people have mentioned the impact on people's mental health. I think Ian mentioned it earlier around, the current COVID impact, isolation, all the current sort of pressures on people. So we're running a very short virtual event on Monday, and this is NHFT, really just making it available to anybody, stakeholders, members of the public, and what we call our members, who are people who are entitled to vote in some of our elections. But we're opening it up just really to talk about mental health, to encourage people to seek help, to tell people a little bit about the services and ways in which they can access them. That's happening on Monday, 2 to 4 o'clock. And people free to access, people just need to register in advance to receive a link. So I just wanted to mention that. Please encourage people to access it, because if nothing else, if they know how to access mental health services, I think that would help all of us make sure we're meeting needs. So thank you.
Thank you, Krishna. Any other AOBs? Okay, if not, we can wrap up with some take-home message. I've been actually really quite enthused by this meeting. I think it's, despite where we are,
just at the key moment, our chair.
Take a breath. Nikki,
I was looking forward to that bit.
Is he going to come back? Let's see.
so I think, have I gone?
You don't have to start in
the middle of
my my big moment, robbed. Oh dear. So basically, just my thoughts on this meeting is that it's actually far more positive than I thought it would be. I think despite where we are with COVID and all the awful problems, we've got some great stuff going on with the children's services. We've got a new team. The ICAN is excellent. The feedback from the ICS is superb. And the work at Kettering with HIP2 looks really strong as well. So I think moving forward with the two unitaries, tying that all together, is actually putting us in a really strong position, despite the current pandemic times that we're living through. So just to say thank you to everybody who's been involved in all of that work. It's truly exceptional. We do meet again. The next meeting is on the 25th of March at 9:30 via Zoom. So if I don't see you all before then, stay safe and see you then. Cheers.
Thank you.
Bye.